So thank you very much. That's a real pleasure to be here with you. I'm unfortunately unable to speak or even understand German, but you have certainly been said how much the epilepsy surgery was the major part of my interest in medicine and major part of my clinical practice. Thus, to be here in such a great institution with such important scientific contribution in the field of epileptology is really a great honor and pleasure, and especially to have the opportunity to speak with you about radiosurgery and its future potential in epileptology is very interesting to me. I've just added this slide before the talk I have prepared, because this is referring to the basic of radiosurgery. One of the first indications of radiosurgery is AVM. We are doing radiosurgery in order to occlude the AVM, in order to prevent bleeding for the patient. We have here a clinical case with the central sulcus, the motor strip, in the motor strip an AVM with epilepsy, no bleeding by the past. The epilepsy is clearly coming from the motor strip with somatomotor seizures with a Bravet-Jacksonian walk. There is absolutely no doubt that the epileptogenic zone is here. And you treat this patient with radiosurgery, and far before the occlusion of the AVM, you see the epilepsy stopping, and the patient have no deficit. And in the second run, you will have the disappearance of the AVM on the angio. But what does it mean? That means that you have made this epileptic cortex no longer epileptic, while not destroying its underlying function, because that's the motor strip. If you destroy the motor strip, you have a deficit. So this case is showing the potential of radiosurgery in the field of epilepsy, which is theoretically to be able to cure the epileptogenicity of cortex without destroying its underlying function. And that's this kind of experience which have led us to investigate the role of radiosurgery in drug-resistant epilepsies, even in absence of AVM or lesion. So we started to try to evaluate radiosurgery in this group of patients in '93. So we have now 16 years of experience, and I will try to summarize what we have learned from these years of experience. I don't have to insist here on the fact that's a team approach and that the contribution of the group of epileptologists, and especially Patrick Chauvel and his group, is extremely important to the success of this project. In '94, in Kyoto, I reported the experience of the very first patient we have treated. We have decided to treat an MTLE patient in '93. And the patients have been quite immediately, which is very unusual, quite immediately seizure-free. I think when you start to do something new, the first patient effect is extremely important. When your first patient is a great success, everybody is very motivated to continue. And we have published some months after this patient. We have been very impressed in the first time by the MRI changes we have obtained in the group of the first 4 patients treated. And we have stopped several years to do it. And following this patient, seeing that we have no complication and we have good result on the epilepsy, we have decided to restart a prospective trial. And I would like to show you now this material. The first thing we have observed, and I'm referring here to the first paper you were published in Epilepsia, the first thing we have observed was quite a good safety efficacy. In this first paper, we have something around 70% of the patients seizure-free at 2 years, and we have no significant complication. We have observed only transient headache and nausea in some of these patients. That was the very preliminary report of our experience. The second observation, which is very specific of radiosurgery in MTLE, is the timetable of the clinical and radiological events. And since this paper we have published in the American Journal of Neuroradiology, everybody around the world working on this group of patients have found exactly the same timetable of event. What you see here is that the patient in blue continued to have quite the same rate of seizures. And suddenly, around 1 year, they have a big peak of auras, just the initial subjective feeling. They may have several hundred a day. And this is disappearing. And quite at the same moment, but not always at the same moment, this can happen much before the MRI changes. Quite at the same moment, you see in orange the gadolinium enhancement in the MRI changes. Some of the patients are late responders, and the peak you have here, that's a group of patients with much more delayed clinical and radiological response. This pattern is very stable, but is highly variable in terms of delay. You have quite always this, but the delay may be different from one patient to the other. This is a picture illustrating a case with, at 9 months, after absolutely nothing. At 17 months, you see contrast enhancement, very impressive with mass effect, and after a while, everything is disappearing. I can tell you that the first patient I treated, I have seen the patient on the Friday that was 9 months after radiosurgery. I saw the patient with a fresh MRI of the morning and absolutely nothing. And the patient have an appointment on the Monday in Orsay in Paris because we were doing systematically PET, 18 FDG PET in this patient. And the neurologist, Frank Sema, called me and told me, have you seen the MRI changes in your patient? I said, no, I have seen the patient with a fresh MRI. There is no changes. Of course there is. And we have observed huge changes on the MRI of the Monday and nothing on the MRI of the Friday. So we have the demonstration, because they were doing MRI systematically with the PET in order to co-register the anatomy to the metabolite. And so we have the demonstration in the first patient that these changes are occurring very suddenly. The third, and certainly the more interesting observation we made in this group of patients was apparently a good sparing of their verbal memory. And that's certainly the point we will discuss more here. We have organized a multicentric study. The majority of the patients were selected to have MTLE on the dominant side. And these patients have they develop no deficit of their verbal memory. Here you see the frequency of the seizures. You see that 65% of these patients were in angle 1, and 9 of these patients have quadranopia. The fourth observation is about the targeting. I was very much influenced by a paper from Wieser about the experience of Yazergil performing amygdalohypocampectomy. When MRI have appeared, they took back all the patients operated by Yazergil, they have scanned the patient, and they have done a work cross-correlating the quality of the outcome according to seizures and the quality of the removal of each part of the temporomesial structures. And they have demonstrated in this paper that the quality of the removal of the amygdala, the quality of the removal of the hippocampus were not related to the probability of seizure cessation. Only the quality of the removal of the anterior parahippocampal cortex was correlating to the outcome according to seizures. Additionally, in this technique, we are very close to the basal forebrain, we are very close to the brainstem, and for me, from the radiosurgical point of view, to be far from these two structures was great, and to be able to recenter my target on the parahippocampal cortex and not the amygdaloid complex and head of the hippocampus was very, very good news. So that's what we have done, and our target is mainly the entorhinal cortex. We have done a study some years after, Motohiro Hayashi have done a study very close to the Wieser study based on our radiosurgery material, and have found exactly the same thing. The quality of the targeting of the anterior parahippocampal cortex was correlating much better to the outcome compared to the other structures. We have also some interesting data from one patient we treated initially. This patient was patient number 2. And at this time, that was absolutely not clear in our mind how to do it. And this patient, we have decided to do it differently. We have done a targeting of the amygdala and hippocampus. That's the opposite of what I'm explaining now. We have done a targeting of the amygdala and hippocampus only. And we have done it with a smaller volume and bigger dose. And what we have observed was a destructive effect some months after. Very nice, teeny destructive effect, very, very accurate. And this patient, when I've shown this patient to Dennis Spencer some years ago, Dennis Spencer told me, oh, that's exactly what I would like to do with gamma knife. That's a true radiosurgical amygdalo-hippocampectomy. And this patient is a perfect disaster. That was a complete failure. But what is interesting in this patient, and the reason why I'm showing this patient, is that this patient, after this lesioning, was still presenting exactly the same typical left MTLE semiology. The very, very typical one with the epigastric aura and the shear wing and all these things. Thus, we have decided to put electrodes in the brain of this patient in order to understand how this patient was mimicking left MTLE without amygdala and without hippocampus. There is a small remnant of the amygdala, so I put an electrode in this remnant, and in fact that was dead. And there is still the parahippocampal cortex, so we implanted the parahippocampal cortex. And what we were able to demonstrate in this patient was the fact that the seizures were really starting from the parahippocampal cortex. So this patient was completely able to generate a true clinical and electrical MTLE left seizure without hippocampus and amygdala, just discharging in air parahippocampal cortex. So the thing is that with radiosurgery, we are doing a small targeting. We are treating volumes lower than 7-8 cubic centimeters. The temporal lobe is quite a large structure, and in the temporal lobe, as you know perfectly, there is room for a certain number of different epileptic syndrome and kind of epilepsies. You can have, lateral epilepsies, lateromesial, mesiolateral epilepsies, and even in the group of the MTLE, we have maybe several subgroup of patients. Some are more initially discharging in their entorhinal cortex, some others are more initially amygdalo-hippocampic. And we are completely convinced nowadays that you cannot treat by radiosurgery all these kind of epilepsies you can treat by a lobectomy. The one you can treat very, very efficiently, that's the patient with mesial temporal lobe epilepsies, because radiosurgery, in my understanding, is the more selective surgery we can propose to this patient. And the more you are selective, the more you have to select correctly the good patient and the good target for surgery. This paper is enhancing this statement. The Lyon group have sent us quite a lot of patients. They have sent us two groups of patients. They have sent us good candidates with clear-cut MTLE, and they have sent us also more complex patients, frequently investigated with SEEG, with the demonstration of involvement of the pole, of the lateral cortex, and some reason not to do microsurgery. VADA test or some other reason, and they were using it as argument to propose palliative radiosurgery. And some years ago, Sylvain Reims from Lyon have analyzed the long-term result of this group of patients and have separated those who were demonstrated to be purely MTLE and those who were MTLE plus. And non-surprisingly, they have demonstrated in this group of patients, they have demonstrated that the results were completely different. The group of patients with pure MTLE, they have exactly the result we have in Marseille, which is around 65-70% angle 1. And the group with MTLE plus, only one, I think, if I remember correctly, only one was cured among this group. So that's that's not a big demonstration. If you do something extremely selective in the mesothelial structure, you will not cure a patient with a more widespread epileptogenic zone. But this is enhancing the importance of a very strict selection. And this is explaining also some of the failures, in my understanding, in the literature with radiosurgery. Another point which is now quite well demonstrated is the importance of the dose. Here you have a table where you can see the major animal models of epilepsies, or radiosurgery of the temporal structures. And you have each time you have one line for the effect on seizures, and you have one line where the authors are reporting the effect on the tissue. And what you see actually is that after 40, 50 gray, you start to have lesioning, and you have a very high rate of seizure cessation. If you are too low, you have a very low rate of seizure cessation and absolutely no lesion. So the good therapeutic window is around 40, 50 gray, which is 50 is at the max, which means that at the 50%, which is our reference dose, that's 25 gray, which is actually exactly the dose we are using in human. There is a study in US where they have tested two groups, 20 gray versus 24 gray, and they have demonstrated that the results were much better in the group with 24 gray. This is our historical series because we have treated, I told you, we have treated at the beginning patients with different regimen of those. We were searching for the best parameters. And what you see here, if you stratify these patients according to dose, you see here that the probability of when we have checked the long-term result of this group of patients, the probability to be seizure-free with these dose, 24, 25 gray, was much better than the probability to be seizure-free with 18 gray, which is now, again, demonstrated in the US study. Another very important observation, which is closely related to our good observation in terms of neuropsychological outcome, is the fact that apparently these people, they don't need to have a radiological destructive effect to be seizure-free. In MTLE, we can discuss it because we have quite significant MRI changes. So you can argue on the point that maybe if the anatomy is normalizing afterward, we have done some kind of lesioning. But for this reason, I will take the group of the patient with hamartoma. That's a very interesting group in the sense that the epileptogenic zone is, at least for the majority of these patients, the lesion itself. So that's a very good model for radiosurgery. And that's usually small lesions we are keeping for radiosurgery. And that's in a context where we cannot afford for aggressive treatment. What is interesting is that the huge majority of the hamartoma young patient treated by radiosurgery with a very good effect on epilepsy have absolutely no, even transient MRI changes. Here, to be very honest, I put one patient who have demonstrated significant changes. But I think nowadays we have done close to 80 hamartoma out of these patients. All the others, they don't have MRI changes in their lesion. So that's the demonstration. You can be efficient on the epilepsy without creating, at least at the radiological level, a destructive effect. Now we start to have long-term results, and Fabrice Bartholomé, who is the neurologist working with us, have followed and reviewed these cases. And he took the patient treated the same way. Of course, we have not mixed the one treated with different regimen of dose or different targets. And he took the patient treated with the protocol we are using nowadays, and that was a group of 38 patients. And we took the one with at least 6 years of follow-up. And this is now published, I think that's a neurology paper. You see here the summary of the paper from Fabrice Bartholomé. You see that there is, all the patients have more than 6 years of follow-up. The average was 8 years of follow-up, and the 60% of the patients at these 8 years of follow-up are in angle 1. If you compare to the rare papers in the literature addressing the issue of the long-term outcome in terms of seizure control after microsurgery, these compare quite correctly to microsurgery on the long term. The good The good news was that we have quite no recurrence. We have, at the beginning, if you compare our group of patients microsurgically operated to our group of patients radiosurgically operated, our results with radiosurgery are a bit lower. But on the long term, because we have not observed recurrences in this arm, these results start to be the same, which is interesting, but that's still a small group of patients. We must not overinterpret this data. The argument for the use of radiosurgery is absolutely not the dangerosity of microsurgery. And here you have two of the biggest papers from the literature showing that the major complications after microsurgery in the temporal lobe are quite rare. And we cannot say we must do radiosurgery because microsurgery is dangerous. That should be absolutely stupid. And microsurgery have the advantage to be immediately efficient. The argument is more a neuropsychological argument in my mind nowadays. This is from Pilcher, showing that you have on operation on the dominant side, you have short-term verbal memory in 40% of his patients. And on your paper from Journal of Neurosurgery 2002, you have demonstrated a very significant risk of worsening of the verbal memory, even if this risk was a bit lower in the group of patients operated selectively. So this risk is objective, is clear, as long as you use the sufficiently sensitive test to show it. This is for you. I promise you I will show you the list of tests we are doing nowadays. Now, additionally, we are doing also the figure of Régis, and that's the testing we are doing to our patients. Nowadays, we cannot claim we have demonstrated the absence of verbal memory deficit after radiosurgery. We cannot claim it because we need a comparative study if we want to demonstrate an advantage over microsurgery. At least what I can do is to report our long-term results, and you see in the patient with a follow-up with a good testing before and after. Unfortunately, some of the first patients treated in 93 don't have a very complete neuropsychological testing before. But in those with a good testing before and after on the long term, we have observed no neuropsychological worsening, no verbal memory deficit till now. And we have, of course, some of these patients improving after radiosurgery, which is also a common observation after microsurgery. This is one of the more impressive cases. She's a young girl treated in 97, in December 97. She was presenting with a left MTLE. This is the battery 144 from Signoret, which is a very French neuropsychological testing, but very sensitive testing. You see here, at the time of radiosurgery, the visual memory was better than the verbal memory, which was impaired. You see, at 9 years, these patients have dramatically improved performances and have better performances in terms of verbal memory compared to visual memories. And you see here the cessation of the seizures delayed around 18 months. And the MRI changes, the seizures and the MRI changes here disappearing gradually. If we accept this observation that really we don't observe verbal memory deficit after radiosurgery, how can we explain it? Maybe that's because we are not lesional, because we are not at all destructive. Maybe that's because we are destructive, but we are destructing something which is much smaller, and we don't have the collateral damage of the approach of the surgery, because when you approach surgically, you have to cut some white matter. And there is a third explanation, hypothesis, which should be that maybe we don't have this deficit, not because we are not injuring the tissue, but because this injury is so much delay in time that the brain has the capacity to adapt and to reorganize, and we don't observe deficit. That's just hypothesis. I'm absolutely unable nowadays to decide what is the real role of each of these hypotheses. I would like just to perform one comment. This is a patient treated at the very early beginning of our experience. And it was really a fantastic case, both from the point of view of the seizures, from the point of view of the social integration, professional life. He was able to work, he was not able to work before. And it was a great success. This patient, I'm sorry, that's very difficult to see the dates. This is 9 months, this is 17 months, 27, 36, and this is 10 years. What you see here is that these patients have displayed the usual range of changes, and after a while, these changes have disappeared. And at this stage, which is 36 months, you have the feeling really that there is nothing left in the MRI. But now, if you take the patient 10 years after, we got the surprise to discover a small, teeny destructive effect. I have no doubt that if surgically you remove only this, you will certainly not cure your patient. I'm sure you will confirm this. So that's certainly not explaining the fact that the patient is completely seizure-free, but that means that we may have the feeling we are absolutely not destructive for time, and on the long run, we have some kind of destructive effects. And maybe we don't have a deficit because that's more limited. So nowadays, as a summary, what is our policy in terms of indication? We have completely shifted for a different paradigm now. Nowadays, we consider a young patient who have a lot to lose, a young patient with a high level of functioning, socially adapted, working, concerned by the risk of microsurgery and concerned by the stop of work, with no atrophy, epilepsy on the dominant side, and few neuropsychological deficit before surgery. I think these patients have a lot to lose, both from a neuropsychological point of view and socially and professionally. And these patients usually are not very severe patients, and they are typically patients who can wait for the delay of effect of radiosurgery, which is taking frequently 1 or 2 years before being effective. And there are additionally patients usually clever enough to understand the proposal of radiosurgery, which is not very easy to understand when you propose a patient to receive a treatment and to have benefit only several years after. This is typically this kind of case. She was a high-level pianist, and she is from Lyon. She is from François Mauguer recruitment. And this patient was left side, have no atrophy, and got a VADA failure because the patient have no deficit, verbal memory deficit, and no atrophy. They have done a VADA, and during the VADA tests, they got a deficit, and they decided that was a contraindication for microsurgery. Everybody knows that the VADA test is not a very sensitive test. You have wrong positive VADA test, of course. So that's not a demonstration of anything. However, because that was a contraindication for microsurgery, they proposed me to do radiosurgery in this patient. And we observed the usual thing, the impressive changes on the MRI and their disappearance. And at 1 year, the patient have stopped to seize with no side effect. And at 2 years, when Jean Isnard have done the testing, neuropsychological testing, the patient was not worsened and was even better from the point of view of the verbal memory. So that's not a demonstration, that's just an example, but that's an interesting example. So what we need is certainly a comparison of microsurgery versus radiosurgery if we want to better support this idea of a sparing of the verbal memory by gamma knife surgery. We don't have it yet, at least not something randomized. We have an interesting series from the US multicentric team. In US, they have organized a prospective trial, and they have found exactly everything we have published. The same timetable of event, the same rate of seizure cessation, the same absence of verbal memory decline, And they have confirmed our results, and they have compared their result of radiosurgery with their result of anterior temporal lobectomy. And you see that they have no significant, no two-test decline on the side of the gamma knife, and they have 20% of their patients with such a decline on the group of patients operated microsurgically. So they have a significant difference. That's not a prospective trial. They have just compared to their historical series of microsurgery. There is in the experimental literature some very intriguing papers. This one is especially intriguing. That's a paper from Detroit, and they have shown in this animal model of kindling that the selective reduction of the density in the dentate granular cell layer and the medial CA3 pyramidal cell layer is prevented or reversed by the irradiation at 25 gray, but not at 18 gray. So they have a protective effect, but additionally they demonstrate the same threshold of dose in this group of animals. Even more intriguing is this paper from Pittsburgh. They have used the experiment of the Maurice water maze. I don't know if you are used to this experiment. If I have understood correctly, you put the rat in water, and the rats have a small platform, and the rat don't like to be in the water. The rat is searching for the platform. And he memorized the place of the platform in spite of the fact he's in the dark, and he's able, by training, to go directly to the platform after a while. When you induce the epilepsy, and here that's a cyanuric acid model, you see that the rat is losing his memory, his spatial memory, and he's still searching for the platform in spite of the fact that he have trained and he's supposed to remember where is the platform. What you see here is that after radiosurgery, you have a decrease of the seizures, and this decrease is much more significant here. That's in red, that's difficult to see. That's much more significant if you use higher dose. And what is interesting is that when you treat the rat with radiosurgery, the rat is able to go directly to the platform and have the pattern of movement of a non-amnesic rat, which is very interesting, even if the human brain is not the brain of the rat. This is a short series from Korea. Sometimes we have a small group of patients operated microsurgically with a failure, and arguments to think that maybe the surgery was not sufficiently posterior. And frequently, in our experience, these patients, they don't want a second surgery, and they are potentially good candidates for radiosurgery, additionally because the volume to be treated is very small. I don't have a review of my cases, but this is a review of a group of cases treated in Korea by Dr. Lee, and you see that he have a certain number of these patients seizure-free after radiosurgery. But the problem in this group of patients was, is it really the reason of the failure, the remnant posteriorly? Is there another explanation to this failure? This is a case from Dr. Lee with this remnant posteriorly treated by gamma knife surgery and with a very good result on the long term. Some comments about the hamartomas. I've just mentioned it because that was a good illustration of the absence of lesioning. These patients, they have a very severe catastrophic epilepsy. The majority, they have an epilepsy worsening with time, very drug resistant, with more and more seizures and cognitive decline and psychiatric comorbidity, falls, and they have frequently catastrophic epileptic encephalopathy. We have some arguments in favor of the major role of the hamartoma itself in these epilepsies, even if maybe there is also secondary epileptogenesis in this group of patients. So nowadays, when we have a small hamartoma with a severe epilepsy, we don't try to understand further, even if there is frontal lobe or temporal lobe semiology associated to the seizures, but we treat upfront by radiosurgery these hamartoma. We have a group now which is close to 80 patients. This prospective trial, that was a group of 60 patients, which is huge because this syndrome is quite rare. And you see that the percentage of patients cured is not huge. But what is very impressive in this group of patients is the fact that the comorbidity is dramatically improved, and even dramatically improved in those who are not completely seizure-free. Sometimes you have a young patient with 300 seizures a day. They are very frequently severe, several hundred of seizures a day. When you see the patient 2 years after, and the patient still continue to have one seizure every 3 months, they are much better from the cognitive point of view, from the psychiatric point of view, from the school performance point of view. And you see that even if the patient is not completely seizure-free, you have done something extremely important for their future development. And what is interesting in this group of patients is that frequently they start to improve from a cognitive point of view and psychiatric point of view before the improvement of the epilepsy, which is something I don't really understand very well. Of course, we don't treat all the hamartoma. This is the classification, the topological classification of the hamartoma. To treat such an hamartoma or such an hamartoma is a completely different story. I think that's a mistake to try to treat by radiosurgery such an hamartoma, because you will fail and the patient will continue to deteriorate during the meanwhile. So we think nowadays that the very small one in the hypothalamus, the type 1, or in the third, or in the floor of the third, are very good indication of radiosurgery. Those are generally not epileptic, and those must be first disconnected microsurgically, and if they still seize, you can treat by radiosurgery the upper part. At least that's our strategy. What is very interesting in this group of patients, at the opposite of what I have said for microsurgery in MTLE, here microsurgery is not so easy, and the risk of microsurgery are absolutely significant, even in the very best hands. And what is very interesting with radiosurgery is that we are extremely safe. The only thing I have observed in this patient is 3 patients with transient poikilothermia, fever, instability of the body temperature with no infection. And interestingly, that was in these 3 cases usually around 1 year, and these have disappeared when the patient have stopped to seize. We got, in 4 of these cases, a transient increase of the seizures some month after, before the improvement. This is a report from the Barrows, where they compare their series from Barrow Institute to the Australian series. They have very, very good results. They are really the 2 best teams in the world for hypothalamic hamartoma. But when you check here the memory impairment, they have a very significant percentage of these young children with a clear deficit of their short-term memory. And this is in spite of the fact that a lot of these patients, they don't have the follow-up and they don't know in detail. But that's young patients, they are very well, but you remove what they got at lunch and they just don't remember what they got. You imagine for school performances, that's not a very good start. So globally, for this group of patients, we think that really radiosurgery is for them a very safe opportunity to prevent them to deteriorate and to stop the epileptic encephalopathy. The earlier is the better. Sometimes we are retreating patients when they are not sufficiently improved, but the big one must be approached with a combination of microsurgery and radiosurgery. As a conclusion, I would like to just show you some pictures corresponding to some different group of patients we have been able to treat, because we got this discussion together some minutes ago. This is a patient with periventricular heterotopia in several areas around the ventricles. But in Grenoble, Philippe Kahn and his team, they put electrodes, they perform ECG, and they have been able to demonstrate that everything was starting from there. They have done a coagulation. The patient was a bit better for some months and have recurred. And we treated this patient with radiosurgery, and this patient have completely stopped to seize 1 year after. This is not a very, very tempting target for microsurgery. We are on the left side, and I think that's a very, very interesting result Small target, well defined by the SEEG, highly functional area, very good result for the patient. This is completely different story. That's palliative radiosurgery. That's a patient with bifrontal epilepsy with a lot of falls and drop attacks. And you see here that we are demonstrating the fact that there was a bilateral frontal epilepsy by the SEEG, and I performed the callosotomy. You see the MRI changes, and you see here the effect, the morphological effect of radiosurgery on the corpus callosum. But here you use very high dosage because the goal is really to cut the corpus callosum, and of course you are destructive in this surgery. And this is maybe for you a very interesting case because you asked me about the benign lesions. This is not a dysplasia, this is a DNT. But that's close in terms of problem, epileptological problem. And with SEEG, we were able to demonstrate that really the epileptogenic zone was limited to the isthmus of the cingulate gyrus, where was the lesion. And we have considered that was not a very good location for microsurgical removal. I don't know if you will be very tempted to remove it. But you see here the effect of radiosurgery from morphological point of view. And this patient have stopped to seize at 1 year. She's a patient from Lyon, I think, from Jean Isnard. So that's a very good result. And clearly, there is maybe a role in the future for small dysplasia when they are located in difficult areas. This is even a more interesting case. That's a patient with a temporal lobe epilepsy with tinnitus at the beginning of the seizures, with obviously involvement of T1, but also of the mesial temporal structures. And I performed the SEEG, and we have the good demonstration of this epileptogenic zone. Cortectomy, and the cortectomy, in spite of the cortectomy, some months after the seizure recurred, and the patient was on the MRI displaying a remnant of the posterior transverse gyrus, Escher gyrus. And the MEG and the MEG gave us some argument to think that the recurring epilepsy was related to this remnant, cortical remnant. And additionally, the patient have tinnitus again, which is, of course, very much clear here. So you see here, we have done a radiosurgery centered on the remnant of the Escher gyrus. We don't have yet the result in this case, but that's interesting because you have the combination of the SEEG, the microsurgery, the MEG and radiosurgery. I think that's a good illustration also for the insular targets in some of these difficult patients. So as a conclusion, I would say that about MTLE, now I'm speaking about MTLE. About MTLE, there is advantages and disadvantages of radiosurgery. We have a delayed effect, which means that these patients, they may die of seizures or SUDEP in the meanwhile, and that's part of the disadvantages of radiosurgery. This means also that these patients have to be followed very cautiously and managed clinically very cautiously during this period. We have some months after these impressive MRI changes. Cannot say that's something very, very positive, even if with time, refinement of the technique and better knowledge, we see that usually that's very well tolerated. And in our experience, these have never been severe enough to lead us to do some surgery, salvage surgery. But these have been reported by Nick Barbaro. There is a target size limitation. If the epileptogenic zone is too large, radiosurgery is clearly not an affordable option for this patient. And those, not all the temporal lobe epilepsies you can cure by a lobectomy can be cured by radiosurgery, which is very selective. We have theoretically, because that's very young patient for the majority, and that's a benign situation, we have to inform the patient about the fact that we are using radiation, and we may imagine in the future a cancer risk. Now the data in the literature about this cancer risk of radiosurgery are at least not in favor of a significant incidence. There is a very big study from Jeremy Rowe in UK comparing the database, the register, UK register of mortality of their patient treated and the incidence of cancer in this group of several thousand of patients treated by radiosurgery. The incidence of cancer is not superior to the incidence of cancer in patients without radiosurgery. However, because there is radiation, that's something we have to speak about with the patient. There is pros for radiosurgery. We don't need craniotomy, we don't need general anesthesia, the patient will stay some hours in the hospital, will go back to work immediately. That's extremely cost effective. We can propose it in case of reoperation, or we can operate after if there is a failure. A second very big positive fact about radiosurgery is that we have the demonstration that we can be effective on the epilepsy without being destructive, at least in some of this group of patients. There is possibly indication of radiosurgery in MTLE, even in patients contraindicated for VADA test or those with more risk of verbal memory deficit after radiosurgery. The US group is coming with the argument that they have apparently less risk, psychiatric risk after radiosurgery. That's not exactly our observation. We have maybe a bit less, but we have some patients with major depressive presentation like we have with microsurgery. And that's compatible with a further microsurgery. So globally, I think that if nowadays we try to improve the result in terms of functional sparing and in terms of quality of life, I think there is room for more, for less invasive techniques, and there is certainly a lot of rationale to try to improve our knowledge about radiosurgery and to investigate further indications and long-term outcome of radiosurgery in this group of patients. However, my experience from contact around the world is that doing radiosurgery for epilepsy is a difficult job. That's difficult because epilepsy surgery is difficult, and you need absolutely to have a very good epilepsy surgery group like here. But you need also to have very good people with radiosurgery, because that's much more difficult to treat epilepsy with radiosurgery than to treat a MET or an AVM. And that's extremely important to insist on this point. But we think that there is a subgroup of patients who may really benefit and have a therapeutic window with radiosurgery. That's a small group. We were calculating that that's certainly less than 10% of our activity of epilepsy surgery. We do, for the majority of our patients, microsurgery. That's rare to propose it to patients because this is really a niche. But for this niche of patients, I think that's extremely valuable. And again, that's a teamwork. I hope I was not too long. Okay, 47.